Welcome to DX Approach, where clinical thinking becomes simple, structured, and effective. On this channel, we break down medical topics into clear, step-by-step diagnostic approaches, helping you understand not just what to think, but how to think. Whether you're a medical student, intern, or preparing for exams, this is your space to master clinical reasoning with confidence. Let's get started. Today, I will be discussing an important and very common complication of diabetes mellitus, which is the diabetic foot. This topic is highly relevant in clinical practice because diabetic foot is a major cause of morbidity, hospital admissions, and even amputations worldwide. Understanding it early can significantly reduce complications and improve patient outcomes. In this presentation, we will start with a case presentation to set the clinical context. Then, we will briefly introduce diabetic foot, followed by its definition and epidemiology. Next, we will discuss the pathophysiology, focusing on how diabetes affects the feet. After that, we will cover the key risk factors that predispose patients to complications. We will then go through the clinical manifestations and symptoms you should look for. Following this, we will discuss how to diagnose and assess diabetic foot. We will also review the classification systems used for diabetic foot ulcers. Finally, we will cover prevention strategies, patient education, and the medical management, including glucose control and infection management. Now, starting with our case, we have a 58-year-old male patient with the initials AK. The information was obtained directly from the patient, and it is considered reliable. This patient represents a typical demographic group affected by diabetic foot complications, as the risk increases with age and duration of diabetes. We will use this case to guide our understanding throughout the presentation. Let's start with a clinical case. We have a 58-year-old male known to have poorly controlled type 2 diabetes mellitus for the past 15 years. He presented with a non-healing ulcer over the plantar surface of his right foot for 2 weeks. The lesion initially began as a small blister beneath the first metatarsal head, which went unnoticed due to reduced sensation in his feet. Over time, it progressively increased in size and developed into an ulcer with foul-smelling purulent discharge. Interestingly, the patient reports only mild pain despite the severity of the lesion, which is highly suggestive of underlying neuropathy. He also noticed surrounding redness and swelling, and more recently developed a low-grade fever. There is no history of trauma, but he does report long-standing numbness and tingling in both feet. Overall, the ulcer has been worsening and is now affecting his ability to walk. On review of systems, the patient reports a low-grade fever, but no weight loss or night sweats. There are no cardiovascular or respiratory symptoms, such as chest pain, palpitations, cough, or shortness of breath. Gastrointestinal and genitourinary systems are unremarkable. Neurologically, he reports numbness and tingling in both feet, which supports peripheral neuropathy. From a musculoskeletal perspective, he has difficulty walking due to the foot lesion, and on skin examination, there is a non-healing ulcer with discharge. In terms of past medical history, he has type 2 diabetes mellitus for 15 years, which is poorly controlled. This is the most important risk factor in this case. He also has hypertension and dyslipidemia, both of which further increase his risk of vascular disease. There is no history of previous surgeries and no prior amputations, which is important when assessing disease progression and complications. He is currently on metformin and insulin, although there is poor compliance with insulin therapy. He is also taking amlodipine and atorvastatin. He has no known allergies. Socially, he is a retired driver with a history of smoking approximately 20 pack years, along with a sedentary lifestyle and poor dietary habits. All of these are significant contributors to his condition. Family history reveals type 2 diabetes in his father and hypertension in his mother. On physical examination, the patient is alert and oriented, but in mild distress due to foot discomfort. His vital signs show a low-grade fever, elevated blood pressure, and a slightly increased heart rate. On local foot examination, there is an ulcer located on the plantar surface under the first metatarsal head. It measures approximately 3 by 3 centimeters, with irregular edges and a base containing slough and purulent discharge. There is surrounding erythema, warmth, and a foul odor, all signs suggestive of infection. On vascular examination, both dorsalis pedis and posterior tibial pulses are weak, and capillary refill is delayed, indicating an ischemic component. Neurological examination shows reduced sensation to monofilament testing, decreased vibration sense, and reduced ankle reflexes, consistent with peripheral neuropathy. Cardiovascular and respiratory examinations are otherwise unremarkable. Based on this presentation, the most likely diagnosis is an infected diabetic foot ulcer with both neuropathic and ischemic components. This is supported by the long-standing poorly controlled diabetes, reduced sensation, and the relatively painless ulcer located at a pressure point. The presence of purulent discharge, erythema, and warmth confirms infection. Additionally, weak pulses suggest an underlying ischemic component. A less likely diagnosis would be an ischemic arterial ulcer. Although the patient has weak pulses, arterial ulcers are typically very painful, occur in different locations such as the toes or lateral foot, and are usually dry rather than purulent. A critical diagnosis that must not be missed is osteomyelitis. This is especially important in chronic or deep infected ulcers, where there may be bone involvement. At this stage, it is not yet confirmed and would require imaging for diagnosis. Now, moving to the definition. According to the World Health Organization, diabetic foot is a complex and multifactorial clinical syndrome. It is characterized by infection, ulceration, and sometimes destruction of deep tissues of the foot in patients with diabetes. This occurs due to the combined effect of peripheral neuropathy, peripheral arterial disease, and external trauma. Over time, these factors lead to progressive tissue damage, impaired wound healing, and, if not managed properly, may result in amputation. In simple terms, diabetic foot is not just an ulcer. It is the result of multiple underlying pathologies working together. Looking at the epidemiology, diabetic foot affects approximately 15 to 25% of patients with diabetes during their lifetime. Each year, about 2 to 4% of diabetic patients develop foot ulcers. At any given time, the prevalence is around 6 to 10%. Importantly, diabetic foot is responsible for about 85% of non-traumatic lower limb amputations. Globally, a limb is lost every 20 to 30 seconds due to diabetes. The mortality is also significant, around 30% at 1 year, and up to 50 to 70% at 5 years after major amputation. Geographically, higher rates are seen in low and middle-income countries and in regions with limited access to foot care services. In the UAE and Gulf region, prevalence is also high due to increased diabetes rates and lifestyle factors. Now, the risk factors can be divided into patient-related and social or environmental factors. From a patient perspective, the most important factors include long duration of diabetes, especially more than 10 years, and poor glycemic control. Peripheral neuropathy plays a major role, as it leads to loss of protective sensation. Peripheral arterial disease contributes by reducing blood supply and impairing healing. A previous history of ulcer or amputation is the strongest predictor of future complications. From a social perspective, walking barefoot, poor footwear, low socioeconomic status, and limited access to healthcare all increase the risk. One important aspect to remember is that diabetic foot is a chronic and relapsing condition. Recurrence rates are high, about 40% within 1 year, and up to 60% within 3 years. This highlights the importance of long-term prevention and follow-up. In terms of microbiology, early infections are usually caused by gram-positive organisms, particularly Staphylococcus species. However, in chronic or severe cases, infections become polymicrobial, involving gram-negative bacteria and anaerobes. Now, moving to the pathophysiology. This is the key to understanding diabetic foot. Diabetic foot results from the interaction of 3 main mechanisms. First, neuropathy. Second, peripheral arterial disease, which leads to ischemia. And third, impaired immunity. All of these are driven by chronic hyperglycemia, which causes progressive tissue damage over time. So, essentially, diabetic foot develops because the patient cannot feel injury, cannot heal properly, and cannot fight infection effectively. Among these mechanisms, neuropathy is the primary driver. Chronic hyperglycemia leads to nerve damage through several pathways. There is activation of the polyol pathway, leading to sorbitol accumulation and osmotic stress. There is also formation of advanced glycation end products, which damage nerve proteins. In addition, oxidative stress and microvascular ischemia reduce oxygen supply to nerves. The overall result is distal symmetric polyneuropathy. Now, looking at the types of neuropathy. First, sensory neuropathy, which is the most important. There is loss of pain, temperature, and pressure sensation. As a result, the patient does not feel trauma. This leads to repeated, unnoticed injury and eventually causes callus formation and ulceration. Second, motor neuropathy. This causes denervation of the intrinsic foot muscles, leading to muscle imbalance. Over time, this results in deformities such as claw toes, hammer toes, and prominent metatarsal heads. These deformities create abnormal pressure points, which significantly increase the risk of ulcer formation. Third, autonomic neuropathy. This leads to loss of sympathetic innervation. As a result, there is reduced sweating, causing dry skin. This leads to skin cracks and fissures, which act as entry points for bacteria. In addition, arteriovenous shunting occurs, meaning the foot may appear warm, but is actually poorly perfused. Overall, autonomic neuropathy increases susceptibility to infection. Now, moving to the second major mechanism, peripheral arterial disease, or ischemia. In diabetes, there is accelerated atherosclerosis, which mainly affects the distal arteries, especially below the knee, including the tibial and peroneal vessels. As a result, blood flow to the foot is significantly reduced. This leads to decreased oxygen delivery, reduced nutrient supply, and impaired angiogenesis. Clinically, this causes delayed wound healing. Over time, tissue hypoxia can progress to necrosis and even gangrene. In addition, poor blood supply limits the delivery of antibiotics to infected tissues, making infections more difficult to treat. The third mechanism is immunopathy, or impaired host defense. Chronic hyperglycemia affects immune function at multiple levels. There is reduced neutrophil function, including impaired chemotaxis, decreased phagocytosis, and reduced bacterial killing. Cell-mediated immunity is also impaired, along with cytokine response. In addition, the hyperglycemic environment promotes bacterial growth, while poor perfusion limits immune cell delivery. Clinically, this results in increased susceptibility to infection. Infections also tend to progress rapidly from cellulitis to abscess formation and potentially to osteomyelitis. Overall, infection clearance is poor. Now, an important point. External trauma is often the trigger that starts the whole process. Even minor trauma can initiate ulcer formation. Examples include tight shoes, walking barefoot, thermal injuries, or small foreign bodies. The reason this becomes serious is because of the underlying pathology. The patient cannot feel the injury due to neuropathy. The tissue cannot heal properly due to ischemia, and infection spreads easily due to impaired immunity. So what starts as a minor injury can rapidly progress into a serious complication. Now, putting everything together, this is the big picture. First, neuropathy leads to loss of sensation and foot deformities. Second, repetitive unnoticed trauma leads to callus formation and eventually ulceration. Third, ischemia prevents proper healing. Fourth, immunopathy allows infection to develop and spread. And finally, this can progress to deep ulcers, osteomyelitis, gangrene, and ultimately amputation if not managed appropriately. Now, moving to the risk factors for diabetic foot. We can broadly divide them into patient-related, environmental, and infection-related factors. Starting with patient-related factors. Long-standing diabetes, especially more than 10 years, significantly increases the risk. This is mainly due to cumulative damage, including neuropathy and vascular disease. Poor glycemic control is another key factor. Chronic hyperglycemia leads to nerve damage, impaired immunity, and delayed wound healing. The most important risk factor is peripheral neuropathy. Loss of protective sensation means the patient cannot feel pain, temperature, or pressure. As a result, minor trauma goes unnoticed. Over time, this leads to callus formation and eventually ulcer development. This is why neuropathy is considered the primary driver of diabetic foot. Now, looking at external and infection-related risk factors. Starting with environmental factors. Inappropriate footwear is a major contributor. Tight shoes can cause repeated friction, while open footwear increases the risk of trauma. Walking barefoot is also important, as it exposes the foot to injuries, especially in patients with reduced sensation. Poor foot care and hygiene lead to missed early lesions, which increases the risk of progression and infection. Now, infection-related factors. Minor untreated wounds and fungal infections, especially between the toes, act as portals of entry for bacteria. Once bacteria enter, infection can rapidly develop, particularly in patients with impaired immunity. Now, looking at some additional patient-related risk factors. Visual impairment is important because the patient is unable to inspect their feet properly. This leads to delayed detection of injuries, allowing minor problems to progress unnoticed. Renal disease is also a significant factor. It is associated with poor wound healing and a higher risk of infection. Finally, smoking plays a major role. It causes vasoconstriction, worsens peripheral arterial disease, and ultimately increases the risk of ischemia. So overall, these factors further contribute to poor healing and increased risk of complications. Now, looking at local or biomechanical risk factors. One of the most important factors is increased plantar pressure. This occurs mainly due to neuropathy and foot deformities. Because of these changes, pressure is not evenly distributed across the foot. Instead, it becomes concentrated in specific areas, especially under the metatarsal heads. Over time, this leads to skin breakdown and eventually ulceration. Another important feature is callus formation. Calluses are actually a marker of high-pressure areas. However, beneath the callus, tissue damage continues to progress. If not managed, this can eventually lead to ulcer formation. Now, revisiting external and infection-related risk factors. Inappropriate footwear plays a major role. Tight shoes cause friction, while open footwear increases the risk of trauma. Walking barefoot is also important, as it exposes the foot to injuries, especially in patients with neuropathy. Poor foot care and hygiene lead to missed early lesions, allowing small problems to progress. In terms of infection-related factors, minor untreated wounds and fungal infections, particularly between the toes, act as entry points for bacteria. This facilitates the development of infection, especially in high-risk patients. Now, moving to the clinical manifestations, starting with neuropathic features. Patients commonly complain of numbness, tingling, and sometimes burning pain, which is often worse at night. As neuropathy progresses, there is loss of sensation, including pain, temperature, and pressure. Motor involvement leads to muscle weakness and foot deformities such as claw toes and hammer toes. In advanced cases, foot drop may occur. Autonomic involvement causes dry skin due to reduced sweating, leading to cracks and fissures. Interestingly, the foot may appear warm due to arteriovenous shunting. A key clinical pattern to remember is that injuries are often painless, and patients frequently say, "I didn't feel it." Now, looking at ischemic features. Patients may present with intermittent claudication, which is calf pain during walking. As the disease progresses, they may develop rest pain, which is typically worse at night and relieved by hanging the leg down. On examination, the foot is often cold, with pallor on elevation and redness when dependent. The skin may appear shiny and hairless, with thickened nails. Peripheral pulses are usually weak or absent. In severe cases, patients may develop non-healing ulcers or gangrene. Ulceration is the core manifestation of diabetic foot. These ulcers are typically located at pressure points, such as the metatarsal heads, heel, and toes. It is important to differentiate between types of ulcers. Neuropathic ulcers are usually painless, occur in a warm foot, and are surrounded by callus. Ischemic ulcers, on the other hand, are painful, occur in a cold foot, and often have irregular edges. The most common type is the neuroischemic ulcer, which has mixed features of both. Infection is a major complication. Locally, patients may present with redness, swelling, warmth, and purulent discharge. There may also be a foul smell. Pain may be minimal if neuropathy is present. Deep infections can lead to abscess formation, sinus tracts, and osteomyelitis, indicating bone involvement. Systemically, patients may develop fever, tachycardia, and, in severe cases, sepsis. Other important findings include callus formation, which is a pre-ulcer lesion and indicates high-pressure areas. Charcot foot is another important condition, characterized by a swollen, warm, and red foot, often mistaken for infection. Over time, it can lead to significant deformity, known as a rocker bottom foot. Additional findings include nail abnormalities, such as thickened nails and fungal infections. Foot deformities, including claw toes and hammer toes, increase ulcer risk. Reduced joint mobility leads to abnormal pressure distribution. Edema can worsen tissue perfusion and may mask infection. Finally, it is very important to recognize red flags. Black tissue suggests gangrene. A deep ulcer with exposed bone raises concern for osteomyelitis. Rapidly spreading infection may indicate a necrotizing infection. And severe rest pain is a sign of critical limb ischemia. These findings require urgent medical attention. Now, moving to diagnosis and assessment of diabetic foot. The first and most important step is a detailed clinical history. This helps us identify the underlying cause, severity, and risk of complications. First, we assess diabetes-related factors. This includes the duration of diabetes, as longer duration increases the risk of complications. We also evaluate glycemic control, usually through a HbA1c history. It is important to ask about previous ulcers, amputations, or hospital admissions, as these indicate a high-risk patient. Next, we focus on ulcer-specific history. We ask about the onset and progression of the ulcer. Pain is an important clue. Pain suggests ischemia, while a painless ulcer suggests neuropathy. We also ask about discharge or foul odor, which may indicate infection. Additionally, history of trauma or inappropriate footwear should be explored. We should also assess associated symptoms. Symptoms of neuropathy include numbness, tingling, and burning sensations. Symptoms of ischemia include intermittent claudication and rest pain. Finally, we assess important risk factors. These include smoking, renal disease, visual impairment, and poor foot care. Identifying these factors helps guide both management and prevention. Now, moving to the physical examination. This should be systematic and focused, including inspection, palpation, neurological assessment, and vascular assessment. Starting with inspection. First, we examine the ulcer itself. We assess the site, especially whether it is located at pressure points. We evaluate the size and depth and examine the base to determine if it is granulating or necrotic. Next, we look at the surrounding area. We check for callus formation, erythema, and swelling, which may indicate pressure or infection. We also assess for foot deformities, such as Charcot foot or claw toes, as these contribute to abnormal pressure distribution. Next is palpation. We assess the temperature of the foot, whether it is warm or cold, which helps differentiate between infection and ischemia. We check for tenderness, and we assess for fluctuation, which may indicate an underlying abscess. Neurological assessment is essential. We use the 10-gram monofilament to assess protective sensation. We also assess vibration using a tuning fork, as well as proprioception and reflexes. Loss of sensation confirms peripheral neuropathy and indicates a high risk for ulceration. Finally, we perform vascular assessment. We palpate peripheral pulses, including the dorsalis pedis and posterior tibial arteries. We assess capillary refill, and we look for skin changes, such as pallor, hair loss, or shiny skin. These findings help identify peripheral arterial disease. Now, moving to special bedside tests. The ankle brachial index, or ABI, is used to assess peripheral arterial disease. An ABI of less than 0.9 is diagnostic of PAD. Another important test is the probe-to-bone test. If the probe reaches bone, this strongly suggests underlying osteomyelitis. Next, we perform laboratory investigations. HbA1c is used to assess long-term glycemic control. A complete blood count helps identify infection. CRP and ESR are markers of inflammation. Renal function is important as a baseline, especially before starting certain medications. For microbiology, deep tissue cultures should be taken, not superficial swabs, as they provide more accurate results and help guide antibiotic therapy. Imaging plays a key role in assessment. X-ray is the first-line imaging modality. It can detect late osteomyelitis, gas in soft tissues suggesting necrotizing infection, and Charcot changes. MRI is the gold standard for diagnosing osteomyelitis. It detects early bone infection and also shows soft tissue involvement. For vascular assessment, Doppler ultrasound is used to evaluate blood flow. Advanced tests such as toe pressure and transcutaneous oxygen measurement help assess tissue perfusion and healing potential. Finally, classification systems are used to assess severity and guide management. The Wagner classification is commonly used. Grade 0 indicates a high-risk foot without ulcer. Grade 1 is a superficial ulcer. Grade 2 is a deep ulcer extending to ligaments or muscle. Grade 3 involves deep infection or osteomyelitis. Grade 4 indicates localized gangrene, and Grade 5 represents extensive gangrene involving the whole foot. Diabetic foot can lead to serious local and systemic complications. Locally, infection is very common, ranging from cellulitis and abscess to necrotizing soft tissue infection, which can progress rapidly due to impaired immunity. Osteomyelitis occurs when infection spreads to the bone and should be suspected in deep ulcers or when the probe-to-bone test is positive. Gangrene develops due to severe ischemia, with or without infection. It can be dry, which is ischemic, or wet, which is infected and represents a surgical emergency. Chronic non-healing ulcers occur due to a combination of ischemia, infection, and persistent pressure. Systemically, severe infection can lead to sepsis, which is life-threatening. Amputation is one of the most feared complications and can be minor, such as toe amputation, or major, such as below or above knee. There is also increased mortality, especially after major amputations. Functionally, patients may develop reduced mobility, disability, loss of independence, and even depression. Patient education is essential in preventing complications. Patients should inspect their feet daily, including between the toes and the soles. They should maintain proper hygiene, washing with lukewarm water, drying well, and applying moisturizer, avoiding the spaces between toes. Proper footwear is crucial. Patients should always wear shoes, avoid walking barefoot, and check inside shoes before wearing them. They should avoid burns by not using hot surfaces or heating pads and always test water temperature. Patients must seek medical attention early if they notice ulcers, redness, swelling, discharge, or new pain or numbness. Finally, lifestyle modification is important, including good glycemic control, smoking cessation, and regular follow-up. Management starts with proper assessment. We assess the severity of infection, vascular status using pulses and ABI, and the depth of the ulcer using classification systems. We must also check for signs of sepsis and limb-threatening ischemia. General management includes optimizing glycemic control. Wound care involves cleaning with saline, regular dressing, and maintaining a moist environment. Offloading is very important. It reduces pressure on the ulcer. The gold standard is a total contact cast, along with special footwear or bed rest in severe cases. For mild infections, oral antibiotics targeting gram-positive organisms are sufficient. For moderate to severe infections, hospital admission is required with intravenous broad-spectrum antibiotics covering gram-positive, gram-negative, and anaerobic organisms. Surgical management may be needed, including drainage of abscesses, debridement of necrotic tissue, and removal of infected bone. In osteomyelitis, prolonged antibiotics are required, sometimes with surgical resection. If ischemia is present, the patient should be referred to vascular surgery. Revascularization can be done via angioplasty or bypass surgery. Surgical management is indicated in deep infection, necrosis, gangrene, or failed conservative treatment. Procedures include debridement, incision and drainage, and in severe cases, amputation. Advanced wound therapies include negative pressure wound therapy and skin grafts. A multidisciplinary approach involving endocrinologists, surgeons, podiatrists, and wound care nurses significantly reduces amputation rates. Follow-up is essential, including regular wound review, patient education, proper footwear, and control of risk factors. Thank you so much for watching. I hope this video made the topic clearer and easier to understand. If you enjoyed it, please like, subscribe, and share it with others. And comment below what you'd like to learn next.